Well, now that we know that this MARIPOSA combination regimen leads to a significant improvement in survival, we need to take a hard look at these data. Are there some groups that derived more benefit from the combination therapy? If patients stopped one component of treatment, did they still achieve that long-term benefit? Is amivantamab, which really does add toxicity and time, but clearly efficacy as well, is that something that needs to continue that entire time? Can we use a limited course of treatment? As we look to the future, we expect the subcutaneous formulation to be available. This will decrease infusion time, improve patient satisfaction and quality of life. In one study, the PALOMA-3 trial, we did see the suggestion that had an impact on efficacy and survival as well. So we are eagerly anticipating the subcutaneous infusion as a way to more, I think, in a patient-friendly way, deliver this type of treatment. So we're looking for novel therapies. And one of the challenges is that the field moves so quickly. When we have a frontline regimen, we think of how would we use these in different sequence, but before you know it, we have new drugs around the bend. We have antibody drug conjugates emerging. We have different bispecific antibodies emerging. And so the subsequent therapies are rapidly evolving. And that's why really it can be difficult to plan a trial with built-in crossover, because by the time that study matures, the second-line treatment options, the standards of care might have changed and the field looks very different. So that's why I do think we place a lot of stock in survival and seeing that patients are living significantly longer with combination therapy. I do think that needs to be part of the conversation. When we look at these combination therapies as ways to improve outcomes for patients with EGFR mutant lung cancer, but as we take a step back, we really want to see would similar approaches help in other similar disease types, other types of EGFR mutations, other type of alterations altogether. And should we be exploring more aggressive combinations in ALK, RET, BRAF, for example? Are there opportunities there to achieve similar survival gains? Right now, osimertinib is not just used in the stage 4 setting. We use it after chemoradiation. We use it after surgery. Are those settings where more aggressive combination therapy, at least for a brief time up front, could also pay dividends in the long term? So, this could really change a lot of different paradigms and have a lasting impact. Progression-free survival gains are important, but survival gains, overall survival improvement, that is substantial. And it really merits us looking at how we're delivering these targeted agents sort of across the field.